The hardest hit areas are pleading for more masks and other protective equipment as their supplies run low. Dr. Sanjay Gupta is back with us, and also joining us now, Dr. Lerner, an emergency physician in Massachusetts, and Dr. Randall, Director of the Cambia Palliative Care Center at Harborview Medical Center in Seattle. It's good to have all of you with us. I do want to touch just off the top on these supplies, because some of the numbers that we're hearing, specifically what we were given in terms of guidance here in New York City on Friday, the Department of Health coming out and saying, listen, you have to be really careful with how you're using these supplies, especially if healthcare workers or first responders are asymptomatic, even if they've come into contact with people. And then you have the chief of surgery at New York Presbyterian Columbia here in New York City, who said on Friday, each employee will get one N95 mask, and they are responsible for making sure that it stays clean and that it is always available. When we hear something like that, Dr. Curtis, I have to say my first thought was, how often can you reuse that mask, and is that safe?
Yeah, what I would say is that my experience here in Seattle, having just finished a week in the COVID-19 ICU, is that we do have enough supplies, and I was able to use a different mask each time I went into a patient room. But I think we're reasonably worried that that's not going to stay that way if this pandemic really goes the direction we think it could go.
Dr. Lerner, you put up this impassioned Facebook post, and I know it's gotten a ton of reaction. Part of what you were discussing, though, were these CDC guidelines that we all talked a lot about at the end of last week, that if you don't have enough masks, try a bandana or a scarf. And you wrote, make no mistake, the CDC is loosening these guidelines because our country is not prepared. Sending healthcare workers to the front line, asking them to cover their face with a bandana, is akin to sending a soldier to the front line in a t-shirt and flip-flops. Has anything changed since you posted that?
What has changed, I think, is the outpouring of support that my hospital has gotten from the community. We've had people showing up, donating masks, offering to sew masks. It's been very touching. I would say if the military had a shortage of helmets, would we say it's acceptable to wear baseball caps, or would we get to work making more helmets? And I think that's what we need to do in this country, is we need to start making more N95 masks.
We hear so much, Sanjay, about the N95 masks, and then we also hear about the personal protective equipment. Is it your sense that the message is getting out there, not just to the folks who are making these products, and we're hearing about governors basically bidding against each other to try to get what available supply there is, but do you think, as a whole, the population in the U.S. has a sense of what doctors on the front lines, like all of you, are facing on a daily basis?
Well, I don't think so. I don't think most people have a sense of that, and I'll be at the hospital later on, and I know that in order to just see my patients who are not COVID patients, coronavirus patients, I will still need to wear personal protective equipment. But Erica, there have been models sort of predicting how much of this sort of equipment and supplies would be necessary. If you look at some of these models, they predicted that in the midst of a moderate pandemic that you would need some up to 3 billion or so masks. And the reason for that is because as a virus is circulating, you don't know who has it, who doesn't have it, so you have to really put on your personal protective equipment for every patient. This was known. The lay public may not know it, and they may not know what healthcare providers are sort of going through, but I think it's a little frustrating for people who are the planners, organizers in big medical structures to know that, look, it was known that we might need up to 3 billion masks in this sort of scenario. We had weeks to sort of think about this. We're trying to play catch up. Now, there are the numbers there on the screen. We do make a lot of masks, 1.5 billion annually. But we knew there it is, 3.5 billion could be necessary in this sort of scenario, and there's the shortfall. That's a problem. It's a problem that maybe we could have addressed. I don't want to look in the rearview mirror anymore. It's not helpful, but I think that's the part that's a little bit frustrating.
There are lessons to be learned, and specifically as we look at how this has spread, how it has been handled in other countries, and even at this point in other cities. Dr. Lerner, I know you believe that in Massachusetts it's maybe days or weeks behind New York City. What kinds of lessons are you taking from areas like Seattle, like New York, as you prepare?
Yeah, I think we are days to maybe a week or so behind my colleagues on the West Coast and in New York. We are starting to try to conserve N95 masks, particularly as much as possible. I think the N95 mask is probably the most important piece of PPE, but it also includes gowns and gloves. I just wanted to reiterate something that had just been said. For any one patient encounter, you have multiple healthcare workers at the bedside, doctors, nurses, respiratory therapists, and they all need the PPE. So it's not just one mask for one patient. We may be talking 5 or 6 masks for one patient in the ER at one time. And so that really, I think, speaks to the volume of PPE that we need. In Massachusetts, we are starting to conserve. We've been asked to reuse our masks, reuse a mask for about 4 hours during a shift in the ER. And we are trying to do that. We're trying to be cognizant of our supplies.
As you're doing that, Dr. Curtis, you said you've actually seen a little bit of a flattening at your hospital there at Harborview Medical Center in Seattle. What do you attribute that to?
I hope so. I think it's early to say for sure, but what I would say is that over the last 2 weeks, the numbers of new patients, particularly seriously ill or critically ill patients, has been relatively stable. And I'm hopeful, it's early yet, I'm hopeful that the reason we're seeing that stability is because the social distancing, the canceling travel, the public health measures that have been taken are perhaps making a difference. I think I don't want to be overly optimistic. I think we have to worry that it's not having the effect that we want and need it to have. But at least right now, it looks to us like things have been relatively stable, flat.
Well, we'll take that with obviously with a degree of caution. Sanjay, as we look at overall what we're seeing across this country, there are also these interesting new studies, and I know you were tweeting about some of them over the weekend. We talked about some of them earlier this morning. But studies also looking at, you were pointing out what we're seeing as some of the symptoms that may not have been initially things that people would associate in their mind with coronavirus. What are some of those? What should we perhaps be paying closer attention to this morning?
Yeah, I mean, I think we're getting a little bit more insight into the types of symptoms that patients might have, and some of the symptoms that patients might initially have as well. A study out of China where they looked at some of the earliest patients, some 200 patients, and they found that digestive or stomach, GI symptoms were actually there in about half the patients. I mean, initially this was thought to be almost solely respiratory, and I think fever and cough and shortness of breath are still the prevailing symptoms, it sounds like, if you look at these studies. But there were patients who also had diarrhea, who had loss of appetite, who had abdominal pain, even vomiting. The loss of appetite was actually quite common in people who had any digestive systems. About 80% of them had some loss of appetite. Now that can be vague, it can be hard to sort of pin down, but it's just a sense to give people an idea, is there something different in the symptoms that they're having? I don't want everyone to start thinking that every single GI symptom is now coronavirus by any means, but it gives clinicians and doctors, nurses a better chance. One other thing that I just want to amplify what Dr. Curtis was saying, everyone obviously hopes that these measures are sort of flattening the curve. One thing to just keep in mind again, though, is that whatever we're seeing now, it's kind of like seeing the light from a star, right? You know, the light from a star actually emanated a long time ago. The picture that we're seeing right now is sort of behind the curve. It typically takes several days between the time of exposure, the time someone gets sick, and then if they do get tested, it takes a few days after that. So we really could be, 10 to 14 days behind. So I think these next 2 weeks, I think again to Dr. Curtis's point, are going to be really critical. It's to see if the numbers sort of stay flat or not.
And of course, we also have, this is on the heels of the Surgeon General this morning saying this is the week that it's really going to get bad. Doctors Gupta, Lerner, and Curtis, thank you all for being here, answering our questions this morning. And again, thank you for everything that you are doing out there on the front line. Stay safe. John?